It's wonderful to be with you all this afternoon for some special opportunities that we have today. So first, we want to start with presentation of our NAHDO Rising Star Awards. Fabulous recognition for young people in our field. So let me start first with Lindsay Kill. Lindsay is the Data Analytics and Information Chief for the state of Vermont. She serves as an important resource to other users of the Vermont Healthcare Uniform Reporting and Evaluation System, affectionately known as VHCures. This is Vermont's all-payer claims database. She is a subject matter expert in the use of claims data and highly skilled in Vermont's APCD environment. Lindsay continuously takes initiative to make suggestions that allows Vermont's APCD vendor, OnPoint, to make enhancements to data quality and usability. She has participated in NAHDO's Data Quality Forum and serves as a lead for the Vermont user group that helps data users understand and work with the VHCures data set for research projects. Lindsay was also the analytics representative from the state of Vermont on the New England States Consortium Systems Organization, or NESCO, project related. It's their project related to primary care reporting in pharmacy data. She's been involved in multiple studies during her time with the Green Mountain Care Board, which is the agency that oversees the APCD program. She has contributed to many analytic initiatives, including the generation of the expenditure analysis reports, providing detailed analytics for the state of Vermont legislative reports, development of an APCD public use file, and many others. Lindsay has a keen ability to simplify complex data and analyses for public use and understanding. She brings joy to her role and is a pleasure to work with. All of this makes her an outstanding candidate for the NAHDO Rising Star Award. So at this point, we'd like to hear a few words from Lindsay. Lindsay, what would you like to say?
Hi, everyone. Just gonna start by simply saying thank you so much. Thank you to my peers who took part in preparing a nomination for me, and thank you to NAHDO for this huge honor. It was such a wonderful surprise, and I'm still a little bit in shock, so thank you. Thank you to my team and my bosses for all of your support and guidance. I wouldn't be here without all of you, so thank you. I just really love the work I do. I get to support the Green Mountain Care Board's regulatory work in Vermont. I get to help teach other people about using claims. And in some ways, I get to help design what's to come in the future of these data for our state. So I'm really passionate about this work because I believe we can do more with the data we have if it can be structured to be reliable and robust. So I hope that I'm able to help make APCD data both a more complete resource and make it simpler to use in Vermont, and then fingers crossed elsewhere as well. I know this work isn't for everyone, but I'm also just really thankful to have found a group of fellow data enthusiasts here at NAHDO. You're all doing incredible work, and I'm just really appreciative to have the opportunity to take part in that and to work across states and collaborate so frequently with you all. So again, thank you for this award. It really means a lot to me. I hope everyone enjoys the rest of their conference, and I can't wait to get to work with you all in the future. Take care.
Thank you, Lindsay. Our other NAHDO Rising Star is Nicole Fawcett. Nicole has spearheaded efforts to evolve operations for both the Virginia APCD as well as several other VHI data collection programs in both in 2022 and over the past several years. Since becoming the Data Services Manager in November of 2021, Nicole has assumed the lead position within VHI for all APCD and hospital discharge request fulfillment. This is an incredibly large responsibility and a role that she has succeeded in immediately. She was nominated for this award because of her rapid ascent into a key decision-maker role in a mature but rapidly growing health data organization. Nicole embodies the key traits of what someone needs to succeed in a managerial role in our industry. 2022 has been a year of tremendous growth for Nicole, and we expect more of the same in the coming years. Nicole, please share your thoughts with us.
Thank you so much to NAHDO for considering me for this award. It's such an honor, and I feel really grateful. As the data services manager at Virginia Health Information, which is the organization that administers the APCD in Virginia, I can truly say from experience how wonderful it is to be a member of NAHDO and all the work that they're doing for APCDs across the country. And I've really enjoyed my time working with NAHDO and collaborating with its members over these past few years. So there's so much opportunity ahead for NAHDO to continue doing the great work that it's doing, both for APCDs as well as for the other facets of their work. And I'm just really looking forward to continuing to grow and learn within this community and be a part of all that's to come. So thank you so much again for this incredible honor.
Thank you, Nicole, and thank you, Lindsay, and congratulations. You really do represent the best of the future of NAHDO and our health data organizations. At this point, we're going to pivot and have our opening day keynote, which will be reflections on the past 10 to 15 years in health IT and data. This session was organized by Craig Schneider and is sponsored by Molina Healthcare. So I'd like to invite Dr. Mark Greenwood from Molina Healthcare to take a few minutes and share his thoughts with us.
Thank you very much, Norm, and good afternoon, everyone. As you mentioned, my name is Mark Greenwood. I'm a family medicine physician, and I'm the Chief Medical Officer for Molina Healthcare in the states of Utah and Idaho. And it's certainly our pleasure to sponsor this afternoon's session. Thank you for the invitation. Most of you are probably aware Molina is a managed care organization with a specific mission. We provide government-sponsored healthcare, primarily Medicaid, but also Medicare and Marketplace, to the most vulnerable members of our society. And we recognize that data is of paramount importance for us to be able to manage these populations. On a personal level, prior to joining Molina, I was with Intermountain Healthcare. I was fortunate to work with and learn from one of the pioneers of clinical quality improvement, Dr. Brent James. Historically, healthcare was more of a cottage industry and based on an apprenticeship model and lacking evidence-based practice and measurement systems. Dr. James helped build a philosophy and a delivery system based on the notion that best practices do exist and that measurement systems can be created to ascertain the quality of care at a patient, provider, practice, and even system level. And most importantly, that this data in these systems can be used to improve patient outcomes. Speaking for myself personally and collectively for Molina, we are committed to the principles that Dr. James espoused for continuous quality improvement using data to provide the highest quality healthcare at the lowest possible cost. We're honored to sponsor this session and hope that you all can continue to improve the science of data analytics to improve our ability to deliver quality healthcare. Thank you very much.
Thank you, Dr. Greenwood. We're very appreciative that Molina is interested in health data and especially appreciative of your sponsorship of our activities. At this time, I'd like to introduce our moderator for today's panel, Craig Schneider from HMA. Charles, can you go ahead and put Craig on stage with me? Maybe?
I cannot yet, is the short
Cannot
answer. Nope, I apologize. I'm working on it.
Okay. All right. We'll need to go to Plan B while Craig reappears. But in the meantime, while Craig, this session is critical to the way we learn from each other. So we've invited of our executives from our health data organizations from around the country. We've got on English from Colorado, Ray Campbell from CHIA in Massachusetts, and Ben Steffen from Maryland. And we're going to have them share with us their thoughts and observations over the past 10 to 15 years. I was going to say 15 minutes, but it's been probably but it's actually been 10 to 15 years. So while we're waiting for Craig to magically reappear, and I hope this isn't a technological issue, but we can make it work without. So let's just, there he is.
Yeah.
Let's turn it over to Craig. You're here. And you can go ahead and introduce.
Can you hear me okay?
Panelists. Yes, we're good.
All right. Sorry about those technical glitches. But thanks very much, Norm and Mark. Craig Schneider. I'm a principal with Health Management Associates in our Boston office. I've been active in NAHDO for, have to add it up, 15-ish years, which will actually be very relevant to our conversation today. So you've already been introduced to our amazing panel. And the reason we put this panel together is that the past 10, 15 years or so have been really transformative in a transformative time in health information technology and health data. And I'm wondering if I am the only person who has noticed that this year is the bar mitzvah of the HITECH Act. So the HITECH Act was enacted in 2009. Do the math, 13 years. If people, don't remember that legislation, it was before your time. What that law did was actually literally spend billions, 20, 30, whatever the heck the number was, billions of dollars on health information technology and health information exchange. And of course, that's not the only major development that's happened in this period of time. So we thought it would be informative and hopefully entertaining to bring together three pioneers in health data to reflect on where we've been, think about where we might be going, and give their insights on where we should go. So let's start off by hearing what roles that they had back in the early 2000s and kind of the path that led them to their current positions. And we'll start off with Ray.
Thanks, Greg. It's a pleasure to be here. Always great to be at NAHDO. So let's think. Over the past 15 years ago, I was working with Craig at the Consortium, a multi-stakeholder nonprofit that at that time was focused very much on adoption of electronics and the early days of health information exchange. I did a short consulting period, and then I was at the Massachusetts Group Insurance Commission, which purchases healthcare for state employees, retirees, and municipal employees as well. It's the largest purchaser of commercial insurance in the Massachusetts. Let me reset that. It's the largest purchaser of healthcare in the New England commercial insurance market. And then for 6 years, I've been at CHIA, the Center for Health Information and Analysis.
Great. Anna?
Sure. So starting right in 2000, I had spent my previous healthcare tenure as a part of the payer organization. But starting in 2000, I was president and chief operating officer of Electronic Network Systems, which was a healthcare clearinghouse in which we connected and developed software technologies for payers and providers. And then I basically at the start of 2010, I became the Vice President General Manager for Imagine, which was a for-profit subsidiary of the American Medical Association, which was the development of a platform. We then sold that to AT&T or merged it in with AT&T, and then I ran all of their sales and marketing on their business side. And our mission on the business side of the AMA was to provide contribution margin for the mission of the organization. So we had a pretty high, and it was a large organization, so we had a pretty high bar to set as far as being able to provide enough money for all the work and great work that the AMA did and still does. And then starting in 2014, I became the president and CEO of CIVHC, the Center for Improving Value in Healthcare, and this is where I have been since then. So.
Great, thanks. And Ben, let's hear your story, please.
Thank you, Craig. First off, I think it was actually, she is 13 years old and she just celebrated a bar mitzvah, as a matter of fact. But we're close enough. I've spent the last 22 years with the Maryland Healthcare Commission, so I'm a little bit of a homebody in comparison to my two partners here today. But what I'd like, although the organization has been the same, the mission has changed. We have broad authority for planning for health system needs in the state. We promote informed decision-making. We aim to improve healthcare access in the state. And what that has meant at various stages has really evolved. It captures what I tell many times, that we're healthcare entrepreneurs, which is a concept that I would really encourage listeners today to think about, becoming health data entrepreneurs. It can sometimes scare your masters that you may be a part of the cavalry and not part of the infantry. But I think some imagination and innovation is key to whatever job you have in this important industry and with this important trade association.
Great, thanks. So thinking back on this past 10, 15 years, roughly that period of time, what do you think was the most positive development in health data or health information technology? And we'll start this round with Anna.
There's a lot. I mean, so, and I'm kind of dating myself, I remember back in the 90s where we implemented COBRA on the payer side, and that was a big deal. But I have to say the most positive development was really associated with the HIPAA transactions. And those came about, and the implementation of the HIPAA transactions started in the mid 2000s. 2003 is when things, I think, pretty much started. And really it was about over the next few years about implementing. And even though I believe the number was around 27, there was a number of variable fields, which really meant there was a lack of standards, across, or at least it really impacted your ability to truly standardize. But that was the start. And I think that was really got the ball rolling, for data standards, transactions, and really what the value could be. And it's been a long time coming. The other thing too is, and this is probably going back, a number of years prior to that, but CMS's mandate that anybody that had more than 10 Medicare claims that they were required to submit electronically or via EDI at the time, it forced it really for the entire industry, not just for Medicare, but all the commercial, the Medicaid, all of the various plans really, had to adopt it. And it really pushed and forced the industry to move forward. And I think one of the big things, especially also that was really, really important, was the adoption in the, around the 2010 time period. And, there was the meaningful use and the requirement associated with doing the reporting. There were registry products that came out, but really it pushed the adoption of employee health records and EMRs. So I think those are really, some of the big ones that really helped to catapult electronic delivery and really getting some standards in the data front.
Great, thanks. And nice to hear something positive about HIPAA. Generally, it's something people complain about, but nice to hear that there's
those variable fields were the big challenges at the time. Right. So, but yes.
Okay, Ben, what are your thoughts about the most positive development in health data or IT?
Yeah, I'm going to talk about some more recent developments, but I sort of looking back and channeling 12 to 15 years ago, when you went to these sorts of meetings, you would find on one hand, back in that time, the champions of discharge data sets. And there were these new entrants, the APCDs, and it was, you had to choose one or the other. And then as we moved along that continuum over the last 10 years, there's been the champions of the APCDs, and then the champions of, I think that EHRs and the flood of clinical information that these EHRs are going to produce are eventually going to swamp the importance of APCDs. And I think actually, what I see a really positive, and largely we've seen it as an outgrowth of the pandemic, is the belief that we have to integrate both clinical and administrative data systems that can be effective for care management, public health, and really the integration of the data wherever it is produced into a much richer set of data systems that really benefit a host of stakeholders, not just clinicians, but also the public health community, payers, and even to a increasing extent, consumers. At this meeting today, you're going to, over the next couple of days, you're going to hear a good bit about health data utilities. I think the folks from Maryland are going to talk about our vision for HDUs. And what I think is really a blessing is that over the last 3 years, HDUs have evolved and developed in many, many states. They've come to mean a little bit something a little different in each environment. But what I can say is that there is a strong commitment to integrating all of these data systems and serving a broader range of audiences than we could have served with either the clinical information alone or the administrative information by itself. So I think that's really the most healthy development, that we're no longer forced to choose sides, but we realize that a combination of integrated information systems is the most effective way to move forward.
Great, thanks, Ben. And Ray, what are your thoughts on the most positive development?
I think I echo a lot of what Anna said, in that I think that HIPAA and the High-Tech Act and the Meaningful Use Program had a huge impact on the IT and data landscape industry. And so I think it's and both of those are federal standards efforts. And so I think it's a double-edged sword. I think we have to be careful about sometimes the federal government having two acts and supplanting state innovation or the kind of flexibility that's needed to take account of differences at state individual markets. But I also think it's a recognition that things can't move forward if there are 50 different approaches to, in particular, IT and data issues in healthcare. So I think the federal government, starting the standardization process on the administrative side, and then with the High-Tech Act and the Meaningful Use Program, accelerating the adoption of those, but also significantly standardizing what's in an electronic health record and what the data elements are and what the standards are that you use for capturing those data elements. And so the federal push to create more standards has benefited everyone. But we have to be careful about finding that balance point for federal involvement. But certainly with HIPAA and the high-tech, they got it right.
And I remember we did some programs back in the day about trying to figure out what the right place was between standardization and innovation.
Exactly.
So, I'm mostly a glass half full kind of guy, but, we just talked about the positive developments. Thought we'd take a few moments to think about what might have been the biggest disappointment looking back at this period of time. And we'll start this question with Ben.
Thanks, Craig. Lots of disappointments, but the one that I remember most really goes a bit beyond what we primarily are talking about today, and that is the failure of the state-based exchanges and really the federal exchange as well in 2013 when the ACA first opened for enrollment. I think Maryland might have set the record, but there were some other states that were not far behind in how quickly that system crashed. We like to pride ourselves to say Maryland, along with a couple other states whose names begin with M, who I won't mention, see ourselves as leaders in healthcare reform. We all did pretty poorly, and one of my worst forecasts was that this was going to open up the avenue for a lot of doctoral students in writing why these things failed. That hasn't really materialized, but thinking back about this, a lot of the failures were really putting too much trust, being overambitious, and putting too much trust in information technology companies, some of whom really oversold their capacity. States, Kentucky, and I actually think Colorado, to name two other states, who thought a little bit smaller, actually made better progress in those early days. So I think the lesson is, as we face and consider innovations moving forward, we blend optimism with realism as we think about systems and improvements we want to make, because sometimes being overly ambitious can produce some pretty negative consequences. Now, the story does have a happy ending, but I'll leave that for another day.
All right, great. Ray, what are your thoughts on the biggest disappointment?
Well, I think it's much larger than just the data issues that NAHDO tends to focus on, but I was very disappointed in no aspects, not every aspect, but a number of aspects of the country's response to the COVID-19 pandemic. And I think there were certainly some data things that we could have done better, and that I do hope there is a post-mortem that's done or a retro to really understand. And I know there are different groups around the country working on it, but to really understand what it is that we could have done better at the data layer. I mean, I think that sort of at the communications and leadership level, something different, but at least at the data layer, I think there are things that we might have expected better than they did, and disappointing. I guess another disappointment would be on some levels, well, I'm not so naive to think that just deploying electronic health records is a silver bullet, but a little part of me was silver bullet. And so I think there was a lot of hope back in the day that if we would just deploy electronic health records, everything would change. And the truth is the healthcare system is very resistant to change. And so we haven't merely automated the cow paths or paved the cow paths, but we also haven't fundamentally changed the nature of healthcare delivery in this country by switching from paper to electronic records. So I'm a little disappointed that that hasn't happened, but I also think that's the type of electrification immediately changed lots of manufacturing processes until several decades had passed. I think the function of electronic health records and health information exchange, it takes a while for those to gestate and produce really meaningful improvements. So I haven't given up hope, but somewhat depends on how you look at it. Is the increase on health equity would be a positive. The difficulties in this country with variations in delivery of care and allocation of resources, those are disappointments. So, but data is the solution for understanding and addressing. So anyway, those are my 22.
Right. And I remember at the time, one of my criticisms was that the money was only flowing to physician practices and hospitals. And I think we're still feeling the repercussions that, nursing homes and home health agencies, behavioral providers, other providers across the continuum of care did not get access to the electronic health records. And I think we're, as a system and society, still paying the price for that decision. Anna, what are your thoughts on big disappointment?
Yeah, so one thing I have to say throughout my career, and especially here at CIVHC, that some of our biggest disappointments were our lessons learned. And I think one of the biggest ones that, as far as learning from these disappointments of things not actually working out the way we've intended, is that incremental and evolutionary change, the slow and steady wins the race, is that, has allowed us to really make some great innovations and progress. But I have to say some of the biggest disappointments, and I'm going to focus on the data side, data and analytics. I'm a data geek by history here. It's really the slow progress of the data standards and really true integration. I mean, we're still working on the clinical side. We're still fine tuning and sweeping the HIPAA, is well moving along from that regard. But the true integration of these different data sets, it has a lot to be desired. And it's just a big struggle, and it continues to be a struggle. Granted, it's extremely complex, but I think we get in our own way from really making some of the movement. The other one that ties with that is the variation in some of the analytic methodologies that disallow true comparability. We struggle with keeping out of the black box and really looking for standards that are out there, but still how a lot of these standards even are employed or utilized within different organizations, whether it's a payer or a provider group or some of these data, organizations, such as the APCDs and the administrators. We've got variation in the analytic methodologies that have impacts and allow for questions to be asked is it relevant? Does this apply to me, et cetera? And I think the big one we have, and I don't know that we've coined it, but we use the word hypnoia, is where people are looking in and they're wringing their hands regarding HIPAA and antitrust. And I think there's still, whether it's utilized as a crutch or whatnot, there's still a real lack of understanding of what are those true limitations and allowances associated under HIPAA and antitrust data allowances. And then you throw SUD in there as well. And, really the current focus still continues to be, and they use a lot of trade secrets and competitive nature of it that, it plays into this conversation associated, and it's more about what you can't do versus what you can do. So I have to say those things really in the data world, are some of the biggest, not only challenges, but disappointments at where we are now versus where we all, as both Ray and Ben alluded to, where we thought we were going to be at this time.
Great, thanks. And this is we're actually doing pretty well on time, so good place to remind anyone who's listening, viewing, please put questions in the chat, and hopefully we'll have a few moments to address them. Our next question, actually giving the panelists a choice, and they might opt to choose to respond to both questions. But so we talked about the most positive development, the biggest disappointment. So one possible question to address is, what was the most surprising development that's happened in this 10 to 15 year period we've been talking about? And then sort of the alternative, to shake it up, kind of looking back, what do you think was your best prediction for what might happen, in 2020-ish? And what do you think was the worst prediction? I would fess up. So I'd love to hear your thoughts. And we'll start this off with Ray.
All right. My connection cut out and I just got back in time for the handoff. So
you want me to repeat the question?
No. In terms of, best prediction, I think each time that one of the tech giants made a foray into healthcare and people, claiming that they're going to disrupt it, it's not clear exactly what it is, that they're bringing. I've predicted that it wouldn't amount to much, and so far the case. Not that it never will amount to much, but things like health vault and such, I think just aren't the way you're going to be able to move the dial on healthcare. In terms of my biggest surprise and my worst prediction are connected, and that's the failure of payment reform make a bigger difference than it has. I mean, I really, years ago, I would have thought that payment reform, alternative payment methods were going to really revolutionize care delivery and make a big impact, and all sorts of things would flow from that. I think they're good and helpful. I think things are happening in the real world, being supported by alternative payment methods, but I haven't seen the kind of systemic changes in healthcare that I thought were going to come if we changed from a few alternative payment methods. Now, the truth is, I think the way we do all this is largely fee for service with an end of year retrospective adjustment. So it has a strong fee for service flavor to it, and actually for people with claims databases.
So I've lost Ray. Is it just me, or is it Ray's connection?
Yeah, we've lost him.
Okay, so sorry about the technical issues. Maybe we can circle back. So Anna, what are your thoughts about surprising development and or best and worst prediction?
So I'll kind of start with, what I thought at the time was really my best prediction. And, we way back, we kept saying that, healthcare data transactions, especially on the it's just like financial transactions. Obviously, a lot more fields than some of the data transactions, but a transaction is a transaction. And so at that time, I had said the healthcare industry is around 20 years behind the financial services industry. Now, I say that I think we're still at least 20 years, maybe we're closer to 40 years now behind the financial services industry. But the reality is we still remain that we are way behind, the financial services industry on true data flow. But, in some ways we're gaining ground, in others not so much. And to tie into what Ray was saying, I have to say the worst prediction is really also about, the incentive payments, the APM, the alternative payment models. There were significant thoughts that there was going from capitation, then fee for service was very cyclical early on, but the momentum that had been gained as it relates to APM and the different types of models, I have to say we all thought and believed, and myself in particular, that it was going to gain great momentum and really drive some of the change. And we're not really seeing that at this point. And I have to say that was definitely not a so hot prediction, 15 years ago or so. I have to say the biggest surprise, and not to keep it negative, but we haven't moved the bar on managing healthcare cost trends. Back in the 90s and the early 2000s, healthcare was around 6% of GDP, and we're now at 20. Never in our wildest dreams would we have thought that it would continue to grow to that level of magnitude that it is right now. And I have to say that's really a surprise, not only for me, but I think for everybody, as to how much healthcare truly has grown. And we need to learn, for example, what Ben has done and his team in the state within Maryland, where they've slowed that down considerably through some of the policy initiatives. But overall, it's continues to grow.
All right. Well, that's a great segue to hear Ben's thoughts on what is the surprising development and or best and worst prediction you may have made going back a decade or so.
Anna, thank you. There's a late breaking story on that. I'll get to it in a moment. Yeah, there is I think a Kurt Vonnegut book who said this first, our best bet has, as he said, the world ended and it had nothing to do with you. The first thing I would mention had nothing to do with it was really the wisdom of a predecessor, that the Healthcare Commission made an enormous commitment to the establishment of a health information exchange in the state. And at one time, that the debate was, could a government agency run a health information exchange? We opted, obviously with significant input from our provider community, that it was really a not-for-profit entity that needed to form the health information exchange. But the Healthcare Commission did play a key role at the very start in designating a state-based health information exchange. It's not the only health information exchange in the state, but by giving that authority, we gave credibility to one organization. The state hospital payment system was a big help in that from the earliest days, the use of hospital rates was a vehicle through which we seeded the establishment of the health information exchange. And certainly the fact that the broad concepts in Maryland of particularly hospitals coming together to work on common shared objectives was key to the early growth of the HIE here in the state. As it developed, the Healthcare Commission took greater interest in activities ancillary to the exchange, including health information privacy and security. Again, consistently focusing not on controlling the exchange itself, but providing some of the parameters around health information exchange. Exchanges, I'll use it as a noun first and then as a verb, how health information exchange operates in the state of Maryland. And I think it's pretty well recognized that the role we played was key to the establishment of and growth of CRISP, now a $60 million enterprise, which probably far bigger than many state HIEs. And what's really encouraging for me to see is not only the relationships that CRISP is forging in other states, but the spread of CRISP personnel throughout the country in roles in supporting other states' activities as well as our own staff who've from those early days invested in learning about the operations of HIEs more generally, and had the vision to look ahead to what is the next step down the road that HIEs would face in terms of challenges and hurdles moving forward. I really want to emphasize, I think that key here was the fact that Maryland had a all-payer hospital rate setting system. Sometimes here in Maryland, we complain that it's too easy for politicians to hang particular funding requirements off the rate setting system, but their use of hospital rates was really a noble enterprise in forming, helping create and continue to establish the HIE here in Maryland. In terms of disappointments, probably my biggest poor forecast was that soon price transparency was going to sweep the country and all consumers were going to become shoppers. That has not happened yet, and I have to concede that consumers are never going to shop for healthcare services like they shop for shoes. And we probably all need to accept that reality, even as we continue to build out initiatives on transparency, recognizing that's really one of the hardest enterprises that we're going to have to embark on. But I think it's key to engaging consumers in lower cost, higher quality healthcare.
Great, excellent point. Ray, towards the end of your remarks, we lost your connection. Is there anything you want to repeat or emphasize just to make sure people caught what you were saying?
No, just I was no. I think I'll stand on what I said. Thanks.
Okay. All right. Hopefully, we were able to capture it in the recording. So now our final question for our panelists before again we open it up to the NAHDO members and convention attendees to ask questions. So I have created a new position of health data czar, and so that position is open and some people may be available to seek such a role. So if you were given that job of health data czar, what is the one thing that you would do to improve the system? And we'll start with Anna on this one.
Okay, so Ben, you kind of set me up a little bit there. So, you know, it's about the whole system itself, not necessarily just the data. But I still believe full transparency of healthcare cost and quality, but you can't, under the current system. I've been in this since the late 80s. I have been in dealing with healthcare claims. And so it is, even when I receive a bill, if I have a hospital stay or whatnot, or a family member does, I have a hard time figuring out how I could have even understood everything that pops in on there. So there has to be the development of a simplified pricing structure that consumers can understand in order to truly have consumerism, and you know that and where they can make decisions regarding price and quality, and if they want to pay premiums for higher quality, what they perceive as higher quality services, great. But right now, the system is so complex that they don't know what they're buying. And they don't know what they're going to be paying for, whether it's the insurance company or whether, it's, whatever portion may be picked up by the consumer or the patient themselves. So that's the one thing: simplified and then full transparency.
It would take a czar to accomplish those things. Admirable
and
views.
a magic wand too. So
a wizard and a czar.
That's right. That's right.
Okay, Ben, what are your thoughts?
So I kind of dodged the question of the czar. I would encourage people to try to think of themselves not as a czar, but as a labor organizer, and try to recognize that you have to bring together stakeholders in order to really make progress in any of the initiatives you're going to launch. One thing that I've found over the years is that many initiatives in healthcare are transactional, and we have, unfortunately, I think, viewed transactional individuals as not trustworthy. Sometimes that's true, but oftentimes in healthcare there are disparate interests, and the coalition you have formed yesterday may not be the coalition that you build for tomorrow. And you have to be able to, I think, work with your stakeholders where they're going to operate, and recognize there may be differences that do not permit collaboration on this initiative, but not give up hope, be optimistic that somebody who's an enemy today may be a collaborator tomorrow, and not parse up the healthcare industry into white hats and black hats. To the extent you can do that, much of the progress we have made, I think, has been trying to find common ground. To answer the question that an old healthcare reformer posed to a group of Marylanders probably 20 years ago, that anytime you propose an initiative, you have to describe the path you're going. Where are you going? How can you get there? What's in it for each of those people, and how they can help. I think that if you think about those 3 or 4 main concepts, you can make a lot of progress in dealing with stakeholders where sometimes you feel like I don't have anything in common with them. And I think building coalitions is important today, as it's been at any point in time, as we really move into a bumpy time in our national history in terms of trying to build coalitions where everyone wants to go to their own corner and throw rocks.
That's great advice. As someone who does stakeholder engagement, I'm going to jot down those 4 steps. I like those messages. Ray, what are your thoughts once you're appointed czar?
Let's hope my connection stays stable. Well, I would want to be thought of as a benevolent czar, and so one of the first things I would counsel is patience. I mean, some of these things just do take time, and they're evolutionary as people kind of integrate the tools into their workflows, improve their workflows, change how they're using the tools. I mean, some things just can't be rushed, and so I think on some levels, patience, is something we need to be aware of while we're going down this path. I would also think that I would encourage organizations to invest more in their data and analytic workers. I think there's a perception out there that data and analytics is largely about, IT platforms and algorithms or whatever. It's a fundamentally human undertaking. And if you don't have the people, if you don't have the skills, if you're not investing in them, there's real limits to, what you can accomplish. So I really think you have to start with the people in the workforce, and that's very hard. Healthcare organizations are hard pressed to find the resources to invest. They have many things that they need to invest in, and the workforce issues are particularly pressing for them. But I think that investing in data and analytic workers is indispensable if you want to be doing a better job with data and analytics. And then at the other end of the spectrum, I would say, I think some aspects of healthcare you can't fix with data. I think there's structural, systemic problems that require legislation and regulation. And there's been it's been hard for the federal government to engage on these issues, but when we have things like HIPAA, when we have things like the HITECH Act, we've had forward progress. So I think, whatever the data czar would do, I think that, it would be to order the federal government to act like adults and, not necessarily go left or right, but come up with some sort of a, sensible plan for the federal government moving things to the next level. So I would want that to be part of what I ordered as the benevolent czar.
Great. So we do have a question that came in and seems related to some of the things Ray was talking about, but anyone can respond to this question. So it's artificial intelligence and health analytics has a lot of buzz. Will it live up to its expectations? And how are you preparing for artificial intelligence in terms of health data governance? Does anyone want to tackle that question?
I guess I'll just initially say, so my organization, CHIA, historically has been much more about the authoritative measure, the authoritative measurement of the past rather than predicting the future. I will say that we're, becoming more, we're moving more into areas of machine learning and data science applications. And so I think that's coming, but at least so far that has been more of a private sector focus than something that we as government agencies have done.
Yeah, and I'll just step in real quick. I think, I think from from an analytic perspective, I think it's more regarding, okay, what are the methodologies? Do we, does there need to be a set establishment of standards as it relates to some of the AI analytics? Whether it's predictive analytics or some of the AI can also be associated with evaluation on a retrospective basis as well. So I think it's really tied into are there going to be standards, and is there going to be that level of comparability, which I think has been one of the ongoing issues historically.
Yeah, I would just add that I think that in terms of the government organizations of which we are quasi-government organizations, I think we're still waiting for the private sector to come up with significant innovations here. AI is growing in importance in clinical decision-making, but I haven't seen any significant movement in true AI tools for use in the spheres that typically oversight agencies are engaged with. But I think there are going to be offerings on the horizon that we'll all want to look at. I think the second point that we realize FDA and others have key roles in is as AI plays an important role in clinical decision making, how is the FDA and other federal regulatory agencies going to deal with the risk and benefit of those products?
Great. So we have two more questions. Let's see if we can address those two questions, and that'll probably take us up to time. So the first is the data item I believe would help providers and patients the most is electronic health record interoperability. Is this possible, and how?
Actually, there's a very exciting development that we're exploring in Massachusetts, which is that we've always kind of considered clinical data elements to be unavailable, to state agencies that like CHIA, that the stuff we collect is largely administrative and financial. But with the maturing of the US CDI data specification that the federal government has pushed as part of the information blocking rules of the US Cures Act, hospitals are now required to make a whole long list of clinical data elements, push button available for exchange if a patient moves to another setting or for a number of other use cases. So if you're an organization that collects case mix data, which CHIA is, we have these established quarterly collections from hospitals. We're now exploring whether we can add clinical data elements from the US CDI to our case mix data, and all indications are that that's going to work. So essentially the door to the EHR has been opened, at least if you have an existing statutory authority to collect data from hospitals, such as a hospital discharge database. So we're effectively adding clinical data elements to our hospital discharge database.
Great. Anybody else want to weigh in on that?
Yeah, I mean, I'll just go ahead and add in that, CIVHC doesn't house itself any clinic, but we work very, very closely with, our HIE. And there's a number of initiatives with the HIEs as well as some other EHR managed for, in particular, some of the FHQs. And the reality is that there be a unifying factor. So our focus at this point is really about working together to have that common master patient index, provider indexes, and that will allow us to more easily be able to integrate the flow of that data. But obviously from a CIVHC perspective, it's more regarding how can we integrate and how can we produce reporting and information that's of greater value to the industry. And we've got to put some of those core infrastructure pieces in place that are being, currently on, there's projects that are in the works right now.
Thanks. And our last question is actually directed towards Ben. What has Maryland done to get state agencies out of their silos and to facilitate stakeholders knowing about health data to be used to inform current climate change policies under review, and using data to comment on environmental impact reports, addressing the impacts on developments, for example, asthma neighborhood levels?
So I'm going to have to defer that. I think that what I would say is that there are efforts to use healthcare information to examine some of these very same questions, but I'd have to follow up with Ms. Hobbs to give her a few more details. Certainly the broad question of breaking out of silos, I think, is relevant to a lot of issues. And what I would say is that the new Maryland model, because it encompasses the entire healthcare economy, has really encouraged Maryland state agencies to share data among other state healthcare organizations. The Healthcare Commission makes the all-payer claim database that we are responsible for available, I think, to virtually all the other major health organizations within the state. We are partners with them and they share important information that they maintain with us. But in terms of the environmental sphere, I'm going to have to follow up with you. I know that Dr. Cliff Mitchell, responsible for environmental assessments, has used some of our data to map high impact areas, but I'd have to get you some more specifics on that. It's not something I'm as well versed in as I should be. What I would also say, a point that I didn't make note of, is that really we do need to make better use of the data that we have. Oftentimes, especially in the area with in health equity issues, we say we don't have good enough data to make decisions, that the first step in any equity initiatives is gathering better data. I'd encourage the attendees to look at some of the postings from Lisa Fitzpatrick, who was, I believe, Deputy Health Commissioner in the District of Columbia. I think she had an article either in Atlantic or Forbes recently where she talks about, the need to move ahead to address health equity, not as a data problem, but as actually real problems that people suffer from. And although it's desirable to have perfect data in the healthcare environment that we live in today, we're never going to meet that measure. And if we use, I don't have the perfect data, I can't do anything as a basis for no action, we're going to be sitting on our hands for a long time to come.
Great. Well, let's stop sitting on our hands and give a round of applause to this amazing panel for all their comments, insights, wisdom, and experience that they shared with us today. And we're really greatly appreciative of your time and remarks today.
Yes,
so
we should thank the rising stars from
Yes.
a bunch of toothless old types. They are the young tigers of tomorrow.
I don't know if that's a coincidence,
Speak
but
for
we
yourself,
bookended this pretty well. True. Thank you, Norm, and thank you, Craig. And Anna
Thanks,
and Ben.
Craig, for
Thank
organizing
you.
this.
Thank
And I
you.
encourage
Thank
all of our
you.
attendees
This
to
was great.